organizing the symposium and for inviting me here. It's been great to be here and to give that talk. So today I'm going to be speaking about results and showing you results of our study that we recently performed and obtained some preliminary data on harmonization of multi-site diffusion MR data from multiple schizophrenia data sets acquired in different places around the world, and I'm going to show you what it can be used for, how it can be interpreted, and what else can be potentially done with it. So those already introduced schizophrenia and white matter. This is pretty much exactly the same slide. I'm just going to quickly repeat that schizophrenia is an interesting disorder with regards to white matter. The onset of symptoms is in late adolescence or early adulthood. It has a genetic risk, developmental disorder, but shows progression, and the age of onset and course of illness appear to be sex-specific. That is the early onset and more severe negative symptoms in males, and relapse rates higher in males, remission rates higher in females. This is what we know mostly from clinical studies, but we would also like to show and to demonstrate whether it agrees with imaging and whether imaging can be sensitive enough to find and to demonstrate those sex specificity. Now, obviously, I'm focusing on white matter in schizophrenia, and the reason for that is that there are numerous studies, both from functional, structural DNA, postmortem fields, that are showing that there's something wrong with the way frontal and temporal lobes are connecting and communicating with each other. Evidence suggests that it might be related to myelination, might be related to oligodendrocytes that are forming myelination surrounding the axons. And when this myelin is abnormal, the connectivity along the axons is abnormal, disrupted, and the timing of connection leads to some of the clinical symptoms that we can observe in patients. Not the only, but one of the first and one of the most powerful methods that can visualize and quantify white matter connections in the brain is called diffusion tensor imaging. As Dost introduced that method, this method, I'm just going to show those slides and repeat that diffusion tensor imaging is sensitive to water movement along the axons, and using that technique, one could not only create those beautiful, colorful images that that can be used to visualize the ellipsoids, the type of water movement inside the brain, and for each of those voxels, this diffusion movement can be measured. The most popular measure for diffusion is called fractional anisotropy, and it more or less relates to either myelin content or the way the axons are bundled together in a voxel, and the way they are parallel to each other. That information can be also used to create something that we call diffusion tractography, connect the vectors along those ellipsoids into the lines, and those lines can be visualized in those whole brain tractography images that reflect more or less the anatomy of the brain, the anatomy of the white matter connections. In theory, white matter can be analyzed and can give us idea about whether the brain abnormalities that we observe in schizophrenia are developmental nature or of degenerative nature. The paper written by Peter Kochunov in 2014 gives the idea about how we could go about testing those hypotheses. what he found interesting and what kind of leads to shifting the field a little bit from looking only at gray matter at the very beginning to now focusing more and more on white matter and connections, is the fact that the onset of psychosis is coinciding with the peak of maturational trajectory of white matter, but not in gray matter. So he suggests that there's something around the time where myelin develops and axons and myelin sheath maturates, the brain maturates, that could make those brains vulnerable to developing psychosis. Now, whether this abnormality or this disease has the developmental disorder or degenerative disorder could be tested by looking at the longitudinal data or data across the large age spectrum, and he suggested that if the curve, the normative curve of brain developmental maturation and aging in healthy controls is seen in red, if the schizophrenia curve is parallel but lower, the peak is lower, and everywhere where the measurements are taken, the fractional anisotropy is lower in patients than in healthy controls, that could suggest developmental abnormalities. If, however, the abnormalities are seen only along the later, the descending part of the curve, meaning there are no differences during the development and maturation, but only during degeneration, that could suggest purely degenerative nature of the disease. Obviously, there's also a potential situation where there's developmental disorder at the very beginning, but this developmental disorder shifts, or developmental lesion shifts the trajectory and make it appear, the differences appear as if they are caused by accelerated aging, but in fact they are purely developmental, and that could also lead to differences in results, or in the way different investigators are reporting differences, group differences, whether they're looking and focusing on age span between 20 to 30 versus 40 to 60. So this is all complicated and obviously requires a large data set. Would be ideal if the data is acquired longitudinally in a very large population, but obviously it's impossible from the technical point of view to keep thousands of subjects and scan them from 10 to 65. Scanners are changing, software is changing, there's attrition of population. So instead, a lot of people are trying to combine already collected data across the lifespan of schizophrenia and build large data sets into some kind of meta-analysis, and then collect and then analyze the data at different stages, age stages and stages of disease, and indirectly draw conclusions about trajectory of schizophrenia pathology. There are already several worldwide collaborative efforts, consortiums that are collecting diffusion data. The biggest one, the one that presents data from over 5,000–6,000 people with schizophrenia and similar number of controls, is called Enigma, founded by Paul Thompson at UCLA. There are smaller consortiums where the diffusion data is combined with, for example, this is a combination of genetic and diffusion data. This is the Naples is a consortium that is looking at the risk to develop schizophrenia patients and the moment they're converting, so that's a semi-longitudinal analysis. BSNP data was presented by Carol Taminga yesterday. There are also smaller data sets available for everybody to download and to play with. And UK Biobank is something that people just started collecting in UK, and it's potentially going to be huge resource. All these collaborative efforts, however, what they're doing is they're collecting data that has been already collected and already analyzed. In that, what I mean by that is that they are already giving investigators from those consortiums calculated fractional anisotropy values per region, and the majority of those consortiums are just running big meta-analysis of on the data. However, what we realized by being part of pretty much all of those consortiums is that when you're collecting data at in different places, even if it's the same identical magnet and you're using identical software, your errors of the measurement can be really big. Sometimes they are close to each other. This is, for example, 2 GE magnets located in 2 different places, 2 Philips magnets and 2 Siemens magnets. Those 6 magnets were part of one of our multi-site studies where we disseminated exactly the same sequence, and then we measured FA in healthy controls matched for age, gender, and IQ in those places. And so, as you can see, the signal over the average over the entire brain between GE and between Siemens can be pretty different. Also, the variance looks different. It's not just scanner and sequence. Sometimes it's the way you pre-process the data that can introduce error and variance. This is the example of 2 different softwares that are used to analyze exactly the same data and derive exactly the same measure, FA, with the same equation, and somehow they come up with different results. So to avoid those kind of errors, and those errors tend to be nonlinear, to avoid those kind of errors, data should be, and it's not always easy, but should be harmonized at the very early stages. We prefer that the data is harmonized before it is converted into FA and analyzed. For that, you need raw data, and obviously once you have raw data and once you have a lot of this data, you can comprehensively characterize white matter changes across the course of schizophrenia. You can identify and characterize global and fiber-specific age-related trajectories measured by FA across schizophrenia lifespan, and you can determine whether white matter pathology in schizophrenia follows an abnormal developmental, maturational, or degenerative pattern. Finally, you can determine whether this pattern varies between white matter fibers across the brain. So over the last 5 years, we've been collecting and trying to harmonize data from 13 different international sites. This slide demonstrates different size distribution of the number of subjects from all of those sites, their age distribution and their sex distribution. We were able to collect data from 600 patients and 492 controls distributed across those 13 international sites. And this is the method that we used. We've published this method extensively. It uses rotation invariant spherical harmonics and basically looks at the signal before the data is converted into diffusion tensor, and tries to eliminate differences that are specific to the site and preserve the differences that are specific to the variance that is specific to anatomy or pathology, physiology, etc. Once the data is harmonized on the signal level, then we follow our normal pipeline, which consists of manual quality control, brain masking, which is done automatically, but then also checked manually and edited manually if needed. Then we use the same software for estimating tensor for all the data sets. Then we register everything to MNI space, use the atlas to extract white matter tracts, and we estimate the DFA for the entire brain as well as for the bundles. So here are the results. So what we were able to see, we first analyzed the entire brain over the skeleton, and that's average FA, and we were able to not only represent and fit those trajectories of brain changes from the age of 11 to 65. This curve represents the trajectory of age-related changes in FA for healthy controls, and this is patients with schizophrenia. So we were able to fit nonlinearly fit the data to the quadratic curve, estimate the peaks, and then at each age compare patients with healthy controls, and this represents the difference, the significant difference at p-corrected for multiple comparisons. So every point here suggests that there was a significant difference at the p-corrected for multiple comparisons. Besides just comparing p-values, and those p-values tend to be high if you have very very large groups, we're also looking at effect sizes, because some of the results of the consortiums, for example, Enigma was showing that even if the p-values are high and survive Bonferroni correction, the effect sizes are pretty low. They're between 0.3 to 0.4 at the best. Our p-values, our effect sizes are showing huge effects from 0.6 at the very early, at the younger ages, all the way to 1.6 at the most advanced ages. Besides looking at the whole brain and trajectories of the whole brain average FA, we're also able to look at individual tracts. First, these are all tracts that are coming from the atlas, and we're comparing them between groups, between healthy controls and patients with schizophrenia. As you can see, the behavior of all those trajectories is not the same across the brain. So we decided to see if there are any patterns in those effect sizes and changes of those effect sizes with age. So we ran clustering algorithm on those tracts, and the algorithm came up with 3 different clusters. One was representing effect sizes that were between 0.2 and 0.5 and were not changing across the lifespan of patients with schizophrenia. And those tracts were mostly limbic related: cingulum left, cingulum right, uncinate fasciculus left, cingulum hippocampal region left and right, inferior longitudinal fasciculus and uncinate on the right side. The second cluster was related to inferior longitudinal and inferior superior frontal fasciculus and superior longitudinal fasciculus. And those were characterized by very small effect sizes at the very beginning of those trajectories, and then increasing effect sizes with advanced aging. And finally, the third cluster, which we call deficit and declining trajectory, was anterior and posterior corpus callosum, where the effect sizes were already at the beginning at 0.7, 0.8 level, and then they decreased significantly all the way almost to 2. So this is basically what the individual clusters look like. And the first cluster looks like it's related purely to developmental pathology, because the changes are just like in Peter Kochenov's paper. They're just like he predicted. They are already present at the moment where we start analyzing the data, and they're consistent all the way across the entire trajectory. The effect sizes also stay the same. The second cluster is a little bit more complicated because it looks like no changes at the very beginning. Here there are no statistical changes, and statistical changes only appear at the moment where the schizophrenics reach the peak of maturation, and then the changes seem to be increasing from 2% per year to all the way to almost 8% per year. But it looks like this is the second situation that Peter also predicted, that where the changes might be developmental, but they cause shift in maturation, in the way the brain develops and maturates. And the differences here, the lack of P differences here does not mean that the processes are not different, just means that the FAs are similar to in those two groups. And then finally the third group is corpus callosum, where the changes are starting significant and then continuing significant all the way to almost 10% per year. With this data, it is also possible to look at now sex specificity, and we haven't analyzed this data very carefully yet, but what we see, and this is just comparing healthy controls, males versus females, what we see is that in some tracts, healthy controls are peaking, males are peaking faster. That means that their white matter maturates and reaches the peak maturation around 30, while it takes longer for females to reach the maturation, but then they are staying longer, sort of with the flat myelin before they their myelin starts deteriorating with age. And there is some evidence in the literature that would suggest that this might be true, and it might be guided by hormones, but by testosterone at the very early stages, where myelin is under the heavy influence of hormones, and myelin maturation is guided by male hormones, and then female hormones around the menopause are protective against demyelination and degeneration. It can be further, well, the other thing that we can do with the data is we can compare males and females with the sort of sex by group interactions, and look at male controls, which would be here, female controls, male patients and female patients, and compare differences, sex by group differences at each stage. We're still working on this data, but this is potentially a big source of new, never before published information. And finally, the clinical relationship between clinical symptoms and white matter pathology could be also explored in this kind of analysis. Unfortunately, the data that we have access to is data that has been collected a long time ago sometimes, and we have access to diffusion, but sometimes not to all the clinical data and behavioral data from those sites. So, for example, clinical data we have only available for 216 subjects, but here one can also differentiate between patients with and without hallucinations, and that data would suggest that if you're looking at hallucinations, the subjects that never experience hallucinations do not have FA pathology at the very early stages of the disease. Until the age of 30, there is no FA difference, or there are patients with hallucinations have way lower FA than patients without hallucinations, who do not differ from healthy controls at the very early stages, and then both of them meet and deteriorate faster than healthy controls. So, in summary, white matter pathology observed along the entire course of schizophrenia. Well, in summary, what we found is that the white matter pathology can be observed along the entire course of schizophrenia, that the results are consistent with normal early developmental lesion. Early developmental abnormality seems to be dynamically interacting with maturation and aging processes, and that this interaction manifests itself in different brain areas at different ages and different disease stages. And I want to thank all collaborators that made this project possible, all my collaborators from Boston and all the founding sources, and thank you for listening.